bit of a dichotomy here because we are jumping straight from a basic clinical examination of the patient, and the idea was to pass the examination, to something which is very important definitely, but in the scheme of things of examination, maybe the examiners would be a bit lenient if your knowledge of antibiotics is not as good as what they would like it to be. So the topic which has been given to me is management of multi-drug resistant organisms and their impact on antimicrobial therapy in intensive care unit. And one of the paradigms of managing infections in the intensive care is to do surveillance of the kind of bacteria and the kind of microorganisms that your hospital is harboring, and maybe develop the sensitivity. And in the process of doing that, we collect certain data on a regular basis. And this is the data that I have collected from my own hospital. This is a 2010 data. And this was the incidence of ICU-acquired infection. The incidence of VAP in my hospital was 4.73. Pretty good data, I must say. The usual numbers are between 10 and 15 in most of the ICUs. But the point that I want to make is that the common organisms that we had was Acinetobacter, Pseudomonas, Klebsiella. Now these, as you would all believe and agree, that they are very difficult organisms to deal with. And then we come to the incidence of catheter-related bloodstream infections. Again, the organisms are Acinetobacter, Klebsiella, Pseudomonas, and to add to that, we have Candida. And the problem with Candida in our setup is that we have Candida non-albicans, the most common species being Candida tropicalis in our ICU. Then we move on to the incidence of UTI. It's not surprising that most of the patients are on antibiotics for day 6, day 7, day 8, day 9, and so forth. And generally, we tend to get a lot of candiduria in our urine samples. By and large, you would agree with me that they are isolates which are commensals, or maybe they are colonizers, and maybe may not be required to be treated. But they have to be dealt with suspicion, because they are there as a part of the flora and fauna of the intensive care unit, and that is why their presence is not to be ignored at any point of time. So just to highlight the kind of problems that we face in our patients whom we manage in the intensive care unit, I've got a case report here. It is a 56-year-old male who came to our ICU. The date of admission was 12th November 2010, barely 2 months ago. And he was admitted with respiratory distress, uremic encephalopathy, probably sepsis with multiple organ dysfunction syndrome. He had a past history of diabetes, hypertension, he was hypothyroid, he had COPD, he had morbid obesity, he was smoking at 220 pack years, and he was addicted to nicotine chewing. So he believed in living life to the full, and so that is the kind of patients who came to us. Initially, we tried to manage him with BiPAP, and then we ventilated him. And then, as usual, the cultures were sent, the procalcitonin levels were sent, and since they were all positive, we started them on a course of antibiotics. So I'm not dealing with the case report of this patient as such, just trying to tell you that the kind of organisms that we grew in this patient. So this patient underwent a percutaneous tracheostomy, hemodialysis was done, vasoactive support was added, manganese, linezolate, colistin, voriconazole. These are the kind of drugs that we used in the patient. This patient, the complication was there from bleeding of trachea, probably after the percutaneous tracheostomy. Just want to highlight the cultures that we obtained. Now this was, the patient was admitted on 12th of November. 1 month down the line, 14th of December, we grew Enterococcus faecium and Candida hemoloni. With the kind of colony count that you are seeing on the right, probably you would agree with me that they are possibly colonizers. But again, as I said, even if they were colonizers and the patient is very sick, you are probably tempted to treat these patients, and that is what we end up doing. And in this case, the Enterococcus faecium that we grew in this patient, the Enterococcus that we grew in this patient was resistant to vancomycin, so we had a vancomycin-resistant Enterococci. But that was not very significant. More significant was the fact that this Enterococci was resistant to linezolate. And that is one thing that I want to highlight to all of you, that we are coming across more and more of linezolate-resistant Enterococci in our setup, and we need to be careful as to what we are doing. So, okay, even if that urine sample was said to be a colonizer, how do you ignore this? This is Klebsiella pneumonia, which came from blood. And this was ESBL negative. It was sensitive only to colistin, and it was carbapenem producing. So by and large, the possibility of using carbapenem in this situation was ruled out. And this was brought out from the dialysis catheter. The dialysis catheter was removed, no doubt about it. And this was this patient obviously was treated, was recovered to some extent, and then stayed on in the intensive care unit. The anatropes came down. Again, to have another bout of sepsis, again 1 month down the line. If you see here, the date was 3rd of January 2011, and this time he grew Acinetobacter bovine, and again it is a CRBSI which is carbapenem positive, sensitive only to colistin and resistant to all other antibiotics that we have come across. So this is the kind of scenario that we are dealing with in our patients. And it is not surprising. This was the SMART study which was published in 2009, and it included 13 major Indian cities, so fairly representative of what the Indian population is all about. And what this study showed was that the production of ESBL, especially in Klebsiella and E. coli, was touching almost 80 to 100% in the Indian cities. And these are various studies which were done in various other hospitals by various Indian authors, which also showed that the incidence of extended spectrum beta-lactamases in India was anywhere between 60 to 70%. And we know that the resistance to antibiotics develops because of these various mechanisms: porine reduction, efflux pump, target site modification, and more often than not, it is the beta-lactamases which are present in the periplasm of the bacteria cell, which is the most common mechanism of resistance employed by the bacteria. And those, we knew when the movement penicillin was introduced, and penicillin we know contains a beta-lactam ring, and the enzyme which hydrolyzes this beta-lactam ring is called the beta-lactamases. So we were aware of the presence of beta-lactamases ever since penicillin came into the picture. But when we tried to counter the presence of beta-lactamases by the introduction of cephalosporins in the early 80s, those enzymes which were able to hydrolyze even the cephalosporins, they were labeled as extended spectrum beta-lactamases. And so this is the Ambler classification of the various extended spectrum beta-lactamases. The only thing that I want to point out is that Class A and Class D are the enzymes which are encoded in the plasmid. Now, plasmids are DNA particles which are present in the periplasmic space of the bacteria. Class C and Class B enzymes are encoded by the chromosomes. AMP-C is a classical example of an enzyme which is encoded by the chromosome and which is inducible. Generally speaking, the AMP-C enzyme which is produced in small quantities, but then due to the presence of some inducers. Now, these inducers, the most notorious inducers are cephalosporins, but we have heard piperacillin tazobactam, we have heard other fluoroquinolones, for example, which also act as inducers. And when these inducers then tickle this bacteria, then these AMP-C are hyperproduced, and even then the genetic material which is present in the chromosome, it gets transferred onto the plasmid, and then it gets transferred to other bacteria to produce this enzymes. So these enzymes were labeled because of various reasons. It's almost arbitrary mechanism by which they were labeled. We have the TEM variety, we have the SHV, we have the PER, which was detected in Pseudomonas, and the most important ones that we are going to discuss more is the CTXM and the OXA group, and that is because the most common type of the ESBL which has been seen in the Indian setup is the CTXM variety, which is resistant to quite a lot of piptazos, but almost until at that point of time when this study was published, were at that point of time sensitive to carbapenem group of. But then, if that story doesn't end there, besides the production of CTXM group of ESBL, most of the bacteria also develop resistance because of co-production of another ESBL enzyme, which is the OXA productions. And here this study shows you that besides the CTXM ESBL, which was there in most of the bacteria, there quite a few, at least 1 out of every 2 bacteria also produced an OXA group of enzyme, thereby making them more resistant to the usual antibiotics. And if that story was not the end of it, we have this New Delhi metabolite beta-lactamases, which was emerging since 2006, and now more quite common. Maybe the kind of culture data that I showed in the beginning in the case study was one of these metallo-beta-lactamases, and the only possible option that is left with us is the use of polymyxin and tigecycline in this case. So what are the treatment options for ESBLs, AMP-C and OXA? Because these are the usual enzymes which the bacteria produce in the Indian setup, and we have to deal with them most of the time in our sickest of the group in the intensive care unit. Second, third generation cephalosporin, aminoglycosides, fluoroquinolones, thimerethoprim, sulfamethoxazole, aztreonam, combination of any of the above drugs, unfortunately, are an absolute no-no. These drugs are just not working. So what are the possible options? We have certain substances which are susceptible as far as ESBLs are concerned. We have carbapenems, tigecycline, BLBLI, and we have other things, other drugs which are may be useful against AMP-C and OXA, which are carbapenem, tigecycline, and polymyxin colistin. So what do we have? So at the end of it, those bacteria which are producing ESBL and also co-producing AMC and OXA group of enzymes, we have only 3 group of antibiotics left with high efficacy in the current Indian scenario. So carbapenems must be considered to be the treatment of choice as they are highly resistant to the hydrolytic activity of the ESBL enzymes, and they have got superior activity against even the AMC group of bacteria producing enzymes. Cefepime. Now that the 4th generation cephalosporin which has been introduced in the market recently, now it is said to be less subjected to hydrolysis by AMC than 3rd generation cephalosporin. But if you go by the latest NCCLS guidelines, it would label that even the 4th generation cephalosporin, that is Cefepime, is not effective in the classical ESBL producers. So maybe Cefepime is not the answer because it is stable against ESBL, stable against AMC and OXA group of enzymes, but it is inactivated by ESBLs. And that is why significant resistance is seen when used alone due to the high ESBL prevalence in India. So what do? So whenever we have to use Cefepime, make sure that we use another group of compound, mostly beta-lactam inhibitor, which is effective against ESBL, and that is why we have come up with several of these combinations now. We have ampicillin-sulbactam, we have got piperacillin-tazobactam, we have cefepime-sulbactam, cefiperazone-sulbactam. So whenever in our setup in Gangaram Hospital, when we are using Cefepime, we tend to use sulbactam as the agent which replenishes the activity of Cefepime, and we use sulbactam because of its inherent intrinsic ability to be effective against Acinetobacter. So the 2 combinations generally works against these group of compounds which are carbapenems producing, and so obviously carbapenems are out. So what are the good news and the bad news of carbapenems? We talked about carbapenems being very effective in this scenario, but then the expanded carbapenem use, which I have seen especially since last 2002 that I have been working. We are using carbapenem left, right, and center in all our patients, and that has selected resistance in quite a few bacteria, and that is why we are in the present scenario in which we are seeing more and more carbapenem resistance, and probably the mechanism of the resistance in the bacteria is due to upregulation of efflux and for the decreased permeability because of porine loss. And as we can see from this study that this was an All India Institute of Medical Sciences study in which there is almost 37% resistance to meropenem in Pseudomonas and Acinetobacter species. So this study was published in 2006, and so carbapenem resistance has become quite a known entity. And as you can see from this particular slide, that when we are using antibiotic, the chances of resistance is all the more. But when we are using meropenem, as you can see there, I'm afraid as you can see that if you're using meropenem, then the incidence of the prevalence of bacteria is at least the multi-drug resistant bacteria is even more. So meropenem has got that inherent potential of producing more and more bacteria in your ICU setup, and that is one of the examples of collateral damage that occurs by the use of high-end antibiotics, and especially for prolonged and continued use of carbapenem group of drugs. And in addition to that, there's always a possibility of increased incidence of Candida infection. So nowadays, 4 or 5 years back, most of the ICUs were not using antifungal drug as a routine. But nowadays, by and large, every ICU that you come across would be using antifungal drug, especially if not in the beginning, then maybe 4 or 5 days down the line of therapy, they usually add an antifungal. And that's not surprising because, as you can see, that the usage of carbapenems leads to the presence of Candida, and the Candida is also not sensitive to usual fluconazole group of medications. So what do we have? So we have only a few antibiotics available to us, and we have to make use of those antibiotics in the best possible manner. And one of the interesting and very novel therapy of using this antibiotics, using the PKPD parameters of the antibiotics, is by using these antibiotics in a continuous infusion. And the common antibiotics that are used are the beta-lactam antibiotics because they are time-dependent antibiotics. Their concentration in the blood, if it is more than MIC for a particular length of time, then the chances of killing the bacteria is all the more. That is the concept on which the continuous infusion is based. And you can see from this study that when meropenem was used as an extended infusion over a period of 3 hours, then the concentration of meropenem in the plasma stayed above the MIC for a longer period of time, and that led to enhanced recovery of these patients. The only problem with using antibiotics in a continuous infusion is because of the stability and the kind of temperatures that we are exposed to in our ICUs. The stability becomes even less. So generally speaking, in our ICU, we do not use imipenem and carbapenem for more than 3 to 4 hours infusion, and obviously we repeat it every 8 hours in the usual setup. So the majority of data does suggest that continuous infusion enables faster attainment of more consistent target concentration, although as of today there are very few clinical data to support this apparent benefit. So what we have done is that we used to start with colistin. Colistin is a workhorse in the intensive care unit, and you just can't escape using colistin, because by and large when you deal with the culture reports, you see that it is resistant to most of the class of antibiotics. It is sensitive to colistin. But we know that colistin is a bacteriostatic compound. We know that colistin acts by punching holes in the cell membranes of the bacteria, and maybe if we use higher concentration of colistin, maybe we could get better results. But the only problem with using high concentration of colistin was that we were very concerned about the nephrotoxicity. I'll be talking about nephrotoxicity in the next few minutes. But at the moment, what we have done is in the ICU, we have gone up on the dosage of colistin. We started with 1 million units 3 times a day, and now we have gone up to almost 6 million units on an average. There are occasions, very rare cases, we have gone up to 9 million units per day. And the problem with colistin monotherapy is that we are giving colistin as a colistimate salt in most of the preparations which are available today. There's a very little slow conversion of this salt into the active drug. And because of this slow conversion of this salt, what happens is that even though the first group of bacteria, they become static in their multiplication, as the drug concentration declines, these static bacteria then they develop resistance against the colistin. And that is the problem with the usage of colistin. And this particular study has shown that after the initial drop in the concentration of bacteria, 24 hours down the line, the bacteria bounce back. And these bacteria which bounce back are the real hardy ones who have been selected. And these are having an inherent resistance to colistin. So what do we do? So what we do is we go back to the age-old hypothesis, especially in Pseudomonas bacteria, which was told to us that don't treat Pseudomonas with one drug, treat it with a combination of drugs. And that is what we do in our difficult to treat patients in the intensive care unit. We use combination of antibiotics, and the most common combinations that we tend to use is the beta-lactam drug. And this particular study showed that which was the drug which was co-prescribed with colistin, and we came across that this particular study showed that the majority of ICUs used meropenem as the drug of choice when they wanted to use another drug with colistin. And this was another study which was basically a meta-analysis which used 34 clinical trials, and the conclusion of this meta-analysis was that the mixed treatment comparison suggests that meropenem has substantial advantage over cefepime, ertapenem, imipenem, cilastatin, and piperacillin tazobactam in the treatment of hospitalized patients with infection. And clinical response was seen in 2/3 of cases. In hospital mortality was 24% when meropenem and colistin were used combinedly, and serum creatinine levels were decreased, actually speaking, not because of the fact that the colistin was a nephrotoxic drug, but because the patient's sepsis parameters improved, and that is why the kidney also recovered. And the deterioration of renal function during colistin therapy was observed in very few patients. So this was again a retrospective cohort clinical study of 258 patients. Most of these patients were susceptible only to polymyxin group of antibiotics. In these patients, what we did was the Phylagus added various other compounds, and in this also there was a significant improvement in the mortality, whether it was Acinetobacter, whether it was Pseudomonas, and whether it was Klebsiella, a group of antibiotics. The nephrotoxicity analysis in this particular study was none of the recorded clinical characteristics like BON, creatinine, cilastatin, and all, including colistin average daily and cumulative dose, were associated with development of nephrotoxicity in this analysis. So what this study showed that perhaps the nephrotoxicity that was associated with colistin was probably an overinflated concept, and maybe it was because of the fact that colistin was replaced by fluoroquinolones in the early 60s, and fluoroquinolones was such a safe group of drugs that the nephrotoxicity was highlighted in these patients. So, ladies and gentlemen, to come back to the summary, that we have very few drugs available to us. If you want to use, you have got no choice but to use colistin in your resistant cases of ICU patients. But then, colistin alone may not be sufficient, so you have to use a beta-lactam antibiotics along with colistin. The most common beta-lactam we use once is the carbapenems. The other is cefepime. If you at all you want to use cefepime in this patient, cefepime may not be useful alone. Cefepime has to be added to a beta-lactam inhibitors. Beta-lactam inhibitors like piperacillin tazobactam are prone to inoculum effects, so especially in very sick patients, you may not be able to use those group of compounds. Tigecycline is again a bacteriostatic compound, and especially in patients with bacteremia, the levels present in the plasma are very low, and that is why tigecycline may not be a good choice, at least alone in patients with bacteremia. Thank you very much.